All right, good morning, everyone. We're going to get started. Today, we are privileged to welcome Dr. Sarah Kim and Dr. Diana Thiara. Dr. Kim is a professor of medicine and directs the UCSF Diabetes Teaching Center. And Dr. Thiara is an assistant professor of medicine and is the medical director of the UCSF Weight Management Program. They both have significant expertise in managing obesity, and we are truly honored to have them come and share today with us on this very important and relevant topic in HIV care. So please join me in warmly welcoming them. Thank you.
Right. So I can't take credit for this really clever title. That was Liz's idea. But I have no disclosures. So I just want to take us through a quick outline. I'm going to be going through a background of obesity, and then actually going to turn it over to Diana, who will be going over pharmacologic approaches to treat obesity. I'll be then speaking to talk about some surgical options for obesity, and then ending with some final thoughts and discussion. So it's been shown over and over again that body mass index is correlated with all-cause mortality. And I like to show this particular study because it's quite large. It's a meta-analysis of over 200 prospective studies over 4 continents. The number of subjects in the meta-analysis exceeded 3 million. What the investigators were able to do in this meta-analysis was to exclude people with any sort of confounders that might erroneously associate BMI mortality. So anyone with pre-existing disease, anyone who's ever been a smoker, and people who died within 5 years at the start of the study. And what you can clearly see is that starting with the nadir BMI of about 22 to 25, with every increment of BMI increase, you have a statistically significant increase of all-cause mortality. And of course, with any BMI study, if you have low BMI, that's also associated with mortality. And just to give you a scope of the problem, globally, about 39% of the human population is overweight, 13% is obese. And in the United States, about 31% of Americans are overweight and 41% are obese. So just getting into the biology of how obesity affects health, in terms of excess adiposity, which is kind of the way I like to think about it, location really matters. And I think with people who take care of those living with HIV, this is not a surprise to you. This concept is not a surprise to you, that there is something called pathologic obesity and then quote unquote metabolically healthy obesity. And what's the difference? So in pathologic obesity, we have less fat in the subcutaneous space. The fat is then located instead in the visceral space in ectopic places such as the liver, the muscle, the vasculature around the heart, around the pancreas. And this leads to chronic inflammation, insulin resistance, and the conditions that we see that are associated with obesity. And people with metabolically healthy obesity, they have excess adiposity, but their adiposity is primarily distributed in the subcutaneous space. And in the subcutaneous space, what you'll see is an expansion of the adipocytes with adipocyte replication, appropriate blood supply or angiogenesis, and sort of that lack of chronic inflammation that we see in the pathologic obesity. So there are 2 types of obesity out there, and it's up to us as providers to determine how excess adiposity is actually affecting the person before us, because it's not the same for everybody. And just a word on obesity as it associates with people living with HIV. So there is increasing prevalence of obesity in people living with HIV due to, number one, the obesogenic environment, which affects all of human society. We have improved longevity and survival in people living with HIV. And then there is some weight association with newer antiretroviral treatments that have differential effects on appetite. And the increasing prevalence of obesity is adding to the heightened risk of metabolic disease and cardiovascular disease among people living with HIV. So before we go slamming HIB, BMI and treating it with a sledgehammer. I want to step back and remember that we always want to be patient-centered when we talk about BMI with our patients. Unless they're coming to see Diana or I, we do not assume the patient wants to lose weight. When they see us, we assume the patient really wants to lose weight. But we don't lead with that, I think, in sort of other sort of situations, such as in primary care. Obesity is well documented to be associated with discriminatory treatment by society, as well as, unfortunately, the medical community. So we want to be sensitive to that. It is well recognized too with people with higher BMIs, especially 35 and 40. There's commonly an emotional or mood component to eating behavior. And unless you are a licensed therapist, I am not, we direct people to the appropriate resources when we can identify that being present. And I really focus primarily on the patient's specific biological consequences of the excess adiposity that relates to that person before me. So I'm looking at laboratory tests like A1C and glucose. I'm looking at cholesterol. I'm looking for the presence of steatohepatitis, menstrual cycles, blood pressure, sleep apnea, and musculoskeletal symptoms, because these are the things that are going to be the most pertinent to the person and be the motivating sort of driver to their treatment. I will also say that it doesn't take a tremendous amount of weight loss to improve these clinical conditions. And that's really what we want to drive home today as well. I think there's an amount of weight loss that the patient desires, maybe for a multitude of reasons. But in terms of improving or reversing metabolic derangements, it's not a tremendous amount of weight. And a prime example of that is the diabetes prevention program. So this randomized control study randomized people who were overweight or obese. The sort of starting BMI on average was 30, and everyone had prediabetes. And the individuals were randomized to either control arm, metformin, and an intensive lifestyle arm. And in the intensive lifestyle arm, there was intensive health coaching. The participants were put on a low-fat, calorie-restricted diet, during which they lost 7% of their starting body weight, and were instructed to exercise 150 minutes per week, moderately strenuous. And the upshot, as a lot of us know, is that the intensive lifestyle arm did the best in terms of preventing diabetes at a few years follow-up, outperforming metformin even. And there are 20-year follow-up studies of the DPP, which showed a legacy duration, like protective effect of the intensive lifestyle arm, even at 20 years. And this is only, quote unquote, not 7% body weight loss, which is not necessarily easy, but it's not like the 20 and 30% that we think about with bariatric surgery. There were similarly impressive outcomes for the same exact lifestyle program for people living with diabetes or having diabetes already in terms of disease regression. So it works really across the board for diabetes and prediabetes. And so just a plug, if your patients are in the SF Health Network, which is patients treated here, the diabetes prevention program is a free resource. You just e-refer. They can either do it at the YMCA or they can do it through an app, and they all get a free gym membership along with that. So please be aware of this resource and refer your patients if appropriate. Okay, so a little bit of biology. So how does obesity occur in the first place? It's still kind of calorie in, calorie out after all of the study. So here we have a mechanism for energy in, which is consuming food. That's kind of the only way to get energy in. That is a voluntary activity, although that's well recognizing there are both hunger and non-hunger eating. And then there's energy out. And we think about physical activity as energy out. That's deliberate energy consumption. But there's a lot of involuntary events going on in the body that consume energy. And actually, this is the majority of our energy expenditure is involuntary activity. So the thermogenic effect of eating, which consumes about 10% of our caloric requirements, the resting metabolic rate, which is actually most of our caloric requirements, and then something called non-exercise activity, which is like me standing up here, waving my arms around, which is not physical activity, but clearly involves some calorie consumption. And the body does regulate sort of energy balance. That's done in the hypothalamus. So here's a hypothalamus. There are a couple competing neurons, sets of neurons in the hypothalamus. This set here, the CART POMC confers satiety, and then the AGRP neuropeptide Y hunger, and they sort of balance to control eating behavior. And the hypothalamus receives signals from the periphery, from adipose tissue in the form of leptin and other adipokines, from the pancreas, including insulin, and famously from the gastrointestinal tract, including GLP-1, cholecystokinin, and other incretins. And how the whole body sort of balances our weight or regulates our weight is really unclear. There are various theories about what our hypothalamus is doing. Is it guarding some sort of weight set point? Is it not really a set point, but a settling point, so like a range? Is it really just kind of only getting involved if we hit a certain high weight or a certain low weight? And in between, it really doesn't care? Or, is there really no regulation at all? And we're just basically a product of our energy in, energy out, and the hypothalamus kind of doesn't sort of want to keep it at a certain weight. So it's actually not clear, and hopefully will be understood in the future. But we do know is that weight gain from overeating varies quite a lot, and it's partly genetic. I like to show this study, which was done, I don't know, now 30 years ago or 20 years ago, 30 years ago, which probably can never be repeated. But twin males were put in a locked dorm for 100 days. I guess you could repeat this, but they were fed in excess of 84,000 calories over that 100 days. Light exercise was permitted, but otherwise, energy consumption was trying to be controlled. And what was interesting about the outcome of the study was the weight gain in response to 84,000 excess calories was quite different from individual to individual. So the weight range on average was like 8 kilograms, but actually would range from 4 kilograms up to nearly 14 kilograms. And this is the exact same situation that you're put in. What this graph is trying to show you is that in the twins tended to gain around the same amount of weight. So this is change in body weight for twin A and versus twin B. And so there is some correlation within twins. But the weight response, the weight gain response was quite different from individual to individual. So clearly there is a genetic component to how we respond to overeating. And, the upshot is the reason why obesity, I think, is becoming so much more prevalent is that we have this hypothalamus that was evolved many hundreds of years ago in a modern food environment. So human ancestors appeared 6 million years ago. Homo sapien appeared 300,000 years ago. Industrialization began 200 years ago. McDonald's opened 70 years ago. And DoorDash has only been around for 10 years. And we have not had sort of this, I would say, a stress of having the ability to order 1,000 calories from your phone to be delivered to you in an hour. That's in some ways sort of an environmental stressor, right? How does your body cope with that ability, that access to food? And I think we're not doing it so well. So our environment promotes overeating. 75% of the US food supply is ultra processed, and I'll explain what that is. And 60% of the food that we consume is ultra processed. Ultra processed foods are cheap, they're calorie dense, they're nutrient poor, and they're very easy to excess and overeat. And sleep disruption and stress increase hunger, and ultra processed foods are the most rewarding. Okay, so what are these foods? There's actually a way to classify foods in terms of their level of processing. It's called the NOVA classification. And a completely unprocessed food would be something that has no alteration coming from nature. I would say that a piece of fruit would be completely unprocessed. A group 2 processed food would be something like an oil, a fat, a salt, and sugar. It's usually a culinary ingredient. So an example of that would be butter. A group 3 processed food would be manufactured by using sort of a food ingredient plus a group 2, like an oil or a salt or a sugar to make it more palatable or to make it more shelf stable. So like maybe a yogurt, but it has some sugar in it. And flavoring in it. And then an ultra processed food is like something basically made in a factory, made out of artificial ingredients, chemicals to make things hyper palatable, very shelf stable, easy to manufacture, cheap. And again, 60% of the food that we eat falls in group 4. It's been shown that we spontaneously overconsume calories on an ultra-processed diet. This is a study from the NIH. Kevin Hall does these metabolic ward studies where he puts people in metabolic wards, controls everything that they eat and they do, and they see what happens. And so this is a study of ad libitum ultra-processed food in the blue versus unprocessed food in the red. This is a crossover study. And so in the 2 weeks that they were in each diet, you can see that the ultra-processed arm ate more calories per day. That resulted in weight gain, whereas in the unprocessed arm, they actually spontaneously lost weight. And that correlated with a gain in fat mass in the ultra-processed arm versus the unprocessed arm. So we kind of naturally eat more on when presented with an ultra-processed diet. So I think this is a big reason why obesity has become a problem, especially in the United States. Another issue with obesity, which makes it a tough condition, is the body's response to attempted weight loss. So I like to show this study, which is the Biggest Loser follow-up study. The Biggest Loser is a competition. You guys are maybe old enough to know this show, but it's a show that basically had people who wanted to lose a tremendous amount of weight over a very short period of time with extreme dieting measures. And there was a research study that looked at all of the winners of The Biggest Loser. So the winner of The Biggest Loser lost the most weight. This is one winner. He was 430 pounds before the show. At the finale of the show, 30 weeks, he was down to 191 pounds. And this was a follow-up study. So at 6 years follow-up for him, he was up to 295 pounds. And so this study looked at the winners of The Biggest Loser, 14 winners of The Biggest Loser. At baseline, they were 149 kilos. At the end of competition, on average, 90 kilos. And at 6 years follow-up, about 130 kilos. Body fat changes correlated with weight changes. And the sort of upshot of the study, the biggest message of the study was the fact that at follow-up, the amount of calories they were burning per day in terms of resting metabolic rate was 500 calories less than a weight-matched counterpart who had not undergone a weight loss process. So if you had never gone on a diet and you were 132 kilos, you were burning a certain amount of calories, but if you had gone through the dieting process and regained back up to 130 kilos, you were burning 500 calories less than predicted for your body mass. So this is what's called metabolic adaptation, meaning when faced with sort of more extreme, weight loss, the body compensates and protects against future weight loss by reducing resting metabolic rate. And so for someone who is struggling with weight loss, maybe has weight cycled many times over their lives and is coming to you and is wondering why it's so hard for them to lose weight, even though they're basically eating like nothing or seemingly very small amounts of calories, it could be a result of a metabolic adaptation to repeated weight loss attempts. So what happens here with caloric restriction is the following. So in a diet, you decrease energy intake as you're supposed to do on a diet, I guess. And then what happens is your body actually compensates by reducing energy expenditure. This is mostly by reducing resting metabolic rate. And then there have been studies to show that appetite is quite heightened during caloric restriction. And so then the the result is that your body weight may go down early in a diet, but the counter-regulatory forces kind of push that weight kind of back up a little, and then you end up regaining and plateauing and when you're trying to do sort of a traditional diet. And the evidence kind of suggests that this is true. I mean, this is a synthesis of 58 behavioral life diet interventions. At the end of 12 to 18 months, the average weight loss was about 4%. And if you looked at commercial weight loss programs, things like Weight Watchers and Jenny Craig, it's about under 5% in terms of average weight loss at the end of a year. So it's really difficult because of these forces, this biological sort of fight against weight loss, to actually have sustained and significant weight loss. So I think that's why treating obesity is critical. I'm going to turn over to Diana, who's going to talk about the pharmacological options for weight loss. Yeah.
We have a question from the chat about lean body mass and BMI. Essentially, does the data on obesity apply to lean but heavy, say, bodybuilders with a BMI of 30?
Oh, sure. Yeah. So BMI is clearly only just your weight as gravity pulls you divided by your height squared. And so it does not tell you anything about body composition. So you always want to keep that in mind. I think from a population level, it's a pretty good predictor of excess adiposity when you have high BMI, but because most of us aren't bodybuilders, but yes, of course, that's something and sometimes waist circumference and things like that would be a better marker of excess adiposity.
Yeah. And just to follow that up, BMI is highly flawed. It was developed in white men, which is not really who we treat today. So we do use it as a population level screening tool, because the better tests of looking at body mass composition are incredibly expensive, both price-wise and time-wise. So it is a screening tool, but just like any other screening tool, you look at your patient as an individual before you decide what their real risk is associated with their excess body weight. Okay, so I'm going to go into pharmacology associated with obesity treatment. But first, we really should think about what is our goal. So when we talk about treating obesity, there is a lot of stigma, and in your patient population as well, there's even a baseline stigma there. So we really have to think about what are we hoping to convey to our patients? And it really comes down to that we want to help our patients improve their health. As Sarah mentioned, we're not really focused on the way someone looks, and we don't want to continue to promote these societal ills that thinness is what we value most. But what we value is helping our patients live long, healthy, and happy lives. We know that obesity treatment can reduce cardiometabolic and mechanical disease rates. And as Sarah mentioned, these improvements can happen at pretty low percentage weight loss. So in the 5 to 10% body weight loss range, we can see improvements in things like hypertension, hyperlipidemia, prediabetes. We also can see improvements in mechanical diseases associated with excess weight, like sleep apnea, lower urinary tract symptoms, as well as lower joint arthritis. So when we think about how to treat obesity today, we think about it with this treatment pyramid. So as BMI increases, we can also increase treatment intensity. You can see here at the base of the pyramid is primary care. And we really want to empower primary care providers to do regular screening and also start the framework for talking about nutrition and activity. As BMI increases and as your comfort level also increases, you also should feel ready to step up that conversation about intensive lifestyle intervention, as well as potentially engaging with medications for weight loss. If your patient's BMI is increasing and you don't necessarily feel comfortable with that comprehensive care, you can start referring to comprehensive weight management programs like ours at UCSF. And what we do is we have an interprofessional approach where we have physicians, dietitians, behavioralists that focus on intensive lifestyle intervention, medications, as well as meal replacement. With a BMI over 30 and some metabolic diseases, patients can also be referred to bariatric surgery. But as Sarah mentioned as well, it doesn't really matter what we want necessarily. It's ultimately up to what the patient wants when they're thinking about their treatment for their excess weight. So lifestyle change really is the crux of what we do, but there are some limitations that make it not necessarily effective in the long run for preventing comorbidities associated with excess weight. So we know that larger weight reductions than that 5% are really critical for optimal control of these comorbid diseases. So if we want to get patients off of medications completely for things like hypertension, hyperlipidemia, we do need higher rates of weight loss. The other bit is that on average, patients regain a third of the weight loss at 1 year after treatment, with increasing weight regain as time goes on. Sarah just explained all of that through that metabolic adaptation. And so these two limitations of lifestyle change are why we oftentimes see patients have success with weight loss at 1 year, but then as time goes on, by year 5, they've oftentimes regained all their weight back and potentially even more. And so that's why medications for obesity are becoming more and more critical as we're treating this. There are currently 6 FDA-approved medications for use in obesity for long-term. The first is orlistat, which is an oral lipase inhibitor. It only has about 3% body weight loss, which is not a clinically meaningful amount of weight loss, so it's not something we use very often in our patients. The next is Contrave, which is an oral combination of bupropion and naltrexone. At year 1, we see around 5 to 8% body weight loss, but there is some level of weight regain. So at 2 years, it's only around 3 to 5%. So again, not that meaningful for long-term reduction in morbidity mortality. The next is Saxenda, which is a daily injectable GLP-1 receptor agonist. At 1 year, around 5 to 10% body weight loss, with retention of 6% at 2 years. And then we get into the bottom 3, which are more meaningful for the longer term use. So Qsymia is an oral pill that's a combination of topiramate and phentermine. At 1 year, we see around 9 to 14% body weight loss with maintenance of 10% at 2 years. And then the bottom 2 are the ones we're really going to focus on today, which are Wegovy, which is a weekly injectable GLP-1 receptor agonist that has 12.5% body weight loss at year 1 with maintenance at year 2. And then the newly FDA approved dual GLP GIP agonist Zepbound, which has 18% body weight loss at 1 year, and then 20.2% at 88 weeks. So before we get into the nitty-gritty, let's just zoom out and think about what are the main things that you should know when you're deciding whether or not to start a medication. So medications are indicated for individuals with a BMI greater than or equal to 30, or a BMI greater than or equal to 27 with a comorbidity associated with excess weight. Medications are still meant to be used as an adjunctive tool to lifestyle change. It's not a replacement for lifestyle change. Medications are meant to be used in the long run, and we'll go through really clear data on that. And I used to say that there was no reduction in morbidity and mortality associated with medications, so you really have to weigh those pros and cons. As of Saturday, we now know that semaglutide has a 20% MACE reduction in individuals with obesity. So the main class of medications that we've been using in the last year have been GLP-1 receptor agonists, and there are 2 currently FDA-approved versions. There's the liraglutide 3.0, which is brand name of Saxenda, and semaglutide 2.4, which is known as Wegovy. I use the brand names only because the FDA and insurance companies are only covering brand names for use in obesity, and there's no way to get around that through prior auths and trying to use alternative forms. So the mechanism of action is really why these medications have been super potent and powerful. The older medications for weight loss that I had discussed, things like Contrave, Qsymia, they acted mostly just centrally via the POMC cart, AGRP, NPY, nuclei, and the hypothalamus to promote satiety. But we all eat for reasons that have nothing to do with hunger. And so that's why those medications had pretty good weight loss at year 1, but then significant weight loss as time goes on. The GLP-1s have totally been a game changer because they act via POMC cart to promote satiety, but they also act peripherally to alter those peripheral hormones. And they also act at the level of the stomach to decrease gastric emptying. So food just sits in your patient's stomach for longer. They increase insulin secretion via the pancreas, and they also improve insulin sensitivity via the liver. So they're really comprehensive medications that are acting on many parts of that brain-gut feedback loop that promote excess weight. So now let's get into the data. So the seminal studies for Wegovy use in obesity are called the STEP studies. So the STEP trial was looking at use of semaglutide in people with obesity. There were 2,000 participants enrolled. They needed to have a BMI greater than or equal to 30, and diabetes was exclusion factor. There was no run-in phase. So what does that mean? Historically, for trials for medications for weight loss, patients had to lose 5% of their body weight through lifestyle change before being randomized to drug or placebo. However, in the STEP trials, they opted not to do that. So everybody who joined the study was initially and right off the bat randomized to drug or placebo. So there was no sort of criteria to show that you could lose weight through lifestyle change first. However, there still was a significant lifestyle intervention component in the study design. So individuals received counseling sessions once a month. They were advised to be on a reduced calorie diet, 500 calorie deficit per day from their baseline. They were counseled on increasing activity about 150 minutes a week, and they engage in some form of daily self-monitoring. So something like a food journal or a dietary app. And they reviewed all of this information at their monthly counseling sessions. So when we think about how are we going to get these results of weight loss with our patients, we want to be sure to be mimicking the study design and how we're actually giving the medications to patients. And the results were quite astounding. So in the study participants who were engaged in the medical weight management protocols, there was 12.5% body weight loss in the semaglutide group. So we see the 15% reduction in the group receiving semaglutide, and we have to be sure to subtract out that placebo effect, which is the 2.4. The media and what your patients will often see is just that 15% number, but you have to remember, subtract out that placebo. And so Wegovy would actually have an expected rate of 12.5% body weight loss. But what's even more profound is that when we looked at the step 5 results, which was use of semaglutide 2.4 for 2 years, patients had maintained that weight loss the entire time. When this data was published, we had never seen anything like this with a medication for weight loss before, oftentimes because of that metabolic adaptation in combination with patients kind of adapting to the way the medications act on the brain. So this is really powerful data showing that this may be an effective tool for medical weight management and achieving long-term sustainable weight loss for our patients. The next question is, how long do patients have to be on this medication? We hear this a lot from our patients and from providers. Can we just start a medication to jumpstart the weight loss, or can we just do this for a couple months and then come off? The data is quite clear that the medications simply do not work that way. So this is the step 1 extension phase. And what they did here was they had individuals in this dark line here on semaglutide 2.4 for 1 year. And then that group came off the medication. And what you can see is a steady increase in body weight. So over the course of 1 year, patients regained 2/3 of their body weight that they had lost. And we expect that number would probably go up even higher as time goes on. But what's even more important is you see that that reduction went from nearly 18% body weight back up to only 5%. So we're not going to see all those major improvements in cardiometabolic disease as you see those lower and lower rates of weight loss that was maintained. So the next question is, do medications actually help patients with reduction in morbidity and mortality associated with excess weight? The answer had always been no, and I've done talks for years and years, and I've always had to say that. But now we have the SELECT trial data. So the SELECT trial was looking at semaglutide 2.4 on cardiovascular outcomes in individuals with overweight or obesity. So the inclusion criteria for this study was individuals with a BMI greater than or equal to 27 with a history of known CVD. So these are patients at baseline who are pretty sick. Again, they excluded individuals with diabetes to not have that confounding factor. And this was a very, very large scale study. Over 17,000 patients were enrolled. Half received semaglutide 2.4, the other half received placebo. About 70% were male, which is very, very atypical for any intervention for obesity. Even in our clinics, or if you were to look at surgery data, it's usually flipped, where 70 to 80% of people who engage in weight loss are women. But because of this likely requirement of known CVD, this population skews male. And the average starting age was also older than most studies for weight loss at 61. The duration of follow-up for most people was around 4 years. And what we see is incredibly encouraging results. So I'm going to have everyone look here, which is B. This is the death from cardiovascular causes. The semaglutide group is here in this orange color. And at the 4-year mark, you can see that there's a reduction in all cardiovascular causes in patients compared to placebo, and the hazard ratio is 0.85. So we see a meaningful reduction. We also see reduction in all primary cardiovascular composite endpoints. So not necessarily leading to death, but any CVD-related outcome over 4 years. And again, a hazard ratio of about 0.8. And the actual numbers were for the placebo group, it was around 8.5% compared to 6% in the semaglutide group, which actually quite closely mirrors what we see in the actual community. So in someone who's around 60, who has CVD, over the course of 4 to 5 years, we would expect to see around 5 to 10% rate of any type of ASCVD risk. So I interpret this as being a very well done study, very large sample size, and things that actually approximate what we see in our patients at large. And so this is incredibly encouraging that using this medication for individuals with excess weight can actually improve their overall comorbidities related to obesity. Okay, so now what are the practical things, side effects? So the main side effects individuals who use GLP-1s can experience are things like nausea and vomiting. Almost everyone has some level of nausea, and it kind of gets better as you dose titrate. I want to be very clear that vomiting is not normal. I think social media and TikTok, all of these things kind of promote this idea that that's just a part of using this medication, but that's just not the case. We do not want to be putting our patients on medications that are making them so sick that they're throwing up and can't eat. Other common side effects are things like abdominal pain, diarrhea or constipation. Some people note headache and fatigue, but this big set of side effects happen. They usually get better as increasing the dose, and you can slow down dose titration if the side effects aren't improving. The last 3 are serious but rare. So in about 1% of patients in the study, both SELECT and the STEP 1, we saw things like pancreatitis and cholecystitis. And then more in the post-clinical data collection, we have seen some new worsening depression as well as suicidal ideation, and we can't predict who that's happening in. So these are 3 super serious things that you want to make sure you talk to your patients about before starting the medication, so there can be true informed decision-making from the patient's standpoint about whether or not those risks are tolerable. In terms of contraindications, there's only 2 absolute contraindications for use. One is a personal or family history of medullary thyroid cancer. This contraindication got this medication a black box warning, but for you all to know, this was seen in the rat studies with GLP-1s. Rats are not the best approximation for human thyroid, so this is incredibly rare, and it is not inclusive of other thyroid cancers. It's very specific to the medullary thyroid cancer. And then the last bit that has been a little bit underreported is that GLP-1s cannot be used in pregnancy. They are not teratogens, but they do increase fetal loss due to placental changes. And because of the long half-life for something like Wegovy, people are supposed to be off this medication for 2 months prior to conception. So you really want to talk to your patients who are of reproductive age about this risk. And in terms of dosing, liraglutide or Saxenda is a daily injection, and semaglutide or Wegovy is a weekly injection that takes 5 months to reach effective dose. So some key facts. Wegovy and Ozempic are the same generics, but they are not the same in the eyes of the FDA or in the eyes of insurance companies. Wegovy is FDA approved for use in obesity, and Ozempic is FDA approved for use in diabetes. We do now see a reduction in morbidity and mortality with semaglutide, and Wegovy is incredibly expensive. It's about $1,400 a month out of pocket, but we're very, very fortunate in San Francisco because things like the SF Health Plan, Medi-Cal, and most of our private insurances do cover medications for weight loss. Medicare, however, does not. I know that's not as applicable here, but it's important if you're thinking about outside of this space. Medicare does not cover any medication for weight loss at this time. So now let's transition into this novel dual GIP-GLP receptor agonist, tirzepatide. It was just FDA approved last week under the name Zepbound for use in obesity. So Zepbound has all these amazing GLP effects, but then it has this added GIP effect of increased lipolysis and fatty acid synthesis. And so when we're thinking about the tirzepatide studies in obesity, these are all called the SURMOUNT trials. And the SURMOUNT trials have been astonishing. So in SURMOUNT-1, individuals with obesity without diabetes were given 15 milligrams of tirzepatide. And what you can see here is 21% body weight loss at 1 year. When you subtract out the placebo effect, that's around 18% body weight loss. And what's even more astonishing is when you look at the patients in subgroup analyses, a third of participants reach over 25% of their body weight loss. This is unlike anything we've ever seen in the medical weight loss field. And this level of weight loss approximates things that we see in the surgical field. So something like a gastric sleeve, you can achieve 20 to 40% body weight loss. And for a third of patients who use this high dose tirzepatide, reached that metric. SURMOUNT-3 was published about a month ago, and they decided to add in this run-in phase. So with the SURMOUNT-3 design, patients had to lose at least 5% of their body weight loss through intensive lifestyle intervention over the course of 12 weeks. This group had a really impressive near 7% body weight loss prior to randomization. And then what you can see here is that after this run-in phase, the group that was randomized to tirzepatide lost 24.3% of their body weight loss. And so when you subtract out that placebo, that's 20%. And this is just on average. So when you think about stratifying again, the whole group, we're going to see closer to a third of the group reaching 30% body weight loss. So how do we think about this in your patient population and people living with HIV? Unfortunately, there's very, very minimal data of any GLP use in people living with HIV. There are only 2 small abstracts, each were about 45 people in Nature, and they included individuals with obesity as well as diabetes, so not specific to this group. Very, very mixed results, and they were looking at all forms of GLP-1, so it wasn't just semaglutide, and it wasn't even just the injectables. And most problematic is that they didn't really report any data on adverse side effects. So how do we think about this? And in the absence of data, I sort of went through my understanding of what risks are associated in your patient population and how we can think about these medications, both in terms of harm and in terms of safety. So in terms of harm, you all know this better than me, but there are baseline risks of pancreatitis associated with both HIV and with certain ARTs. There's also this baseline risk of cholecystitis associated with HIV. Pancreatitis and cholecystitis are also both associated with these 2 medications. And so how do you think about this? Well, if you have a patient who has known pancreatitis and it was because of a medication and you stopped the medication, or they had a gallstone and their gallbladder was removed, then this is probably safe to use. But if they have chronic pancreatitis from their baseline HIV, then it's probably not a good medication. Either way, because of the lack of data, if you do choose to start one of these medications, probably should be monitoring lipase and LFTs monthly as you up titrate to make sure there's no signs of biochemical pancreatitis or signs of increasing bilirubin. But then what about on the other side of things? So we know that individuals living with HIV have higher rates of cardiometabolic disease risk than the average population. There's an increased risk of HFpEF. And we know that semaglutide has shown reduction in symptoms associated with HFpEF, as well as increased exercise function. So this medication may be good for your patients who are showing signs of HFpEF or other heart failure. We also know that there's increased risk of acute MI and coronary heart disease in individuals living with HIV. And as the SELECT trial data shows, semaglutide does have this 20% MACE reduction. And then the last bit is we also know that individuals with HIV have a higher rate and risk of diabetes. And obviously these medications are going to improve that as well. So as you're trying to think through this. Maybe it's doing a study, but if not, for your patients at an individual level, you really should weigh the pros and the cons and see your patient's preferences as well, and do incredibly thorough shared decision-making about if this medication is safe and makes sense for your patients. The computer's frozen. Oh, there we go. Okay, so in the last minute, what is on the horizon? So the GLP-1s and the dual GIP GLP-1 are really exciting, but in the next year or so, we're going to have a lot more to talk about. So most near to us are the oral GLP-1. So you're going to hear about higher dose ribelsis, as well as newer agents like danuglipron. The triple receptor agonist retatrutide is a GIP, GLP, and glucagon receptor agonist that showed 22% body weight loss at 48 weeks in a phase 2. So the phase 3 is in process now. We'll probably hear more in the next year. There's a GLP, GIP antagonist called Amgen 133 that's completed its phase 1. And there's a totally new class of medications called activin receptor inhibitors. The most popular one right now is bimagrumab, and the phase 2 is complete. So there's a ton of things that are about to come up. Your patients will ask a lot of questions, but we really want to make sure we're only prescribing medications once we've seen the phase 3 data come out for safety reasons. So I'm going to pass it back to Sarah to go through surgical approaches to weight loss.
Okay, so just really quickly, well, we don't do surgery, but we refer a lot of patients to surgery. And so I just want to go over the basics. There are 2 bariatric procedures that are done commonly. The first is the vertical sleeve gastrectomy, done in about 80% of cases here. 80% of the stomach is excised from the normal stomach. It's taken out permanently. What's remaining is a narrow tube of a stomach, which can only accommodate a few ounces of food or beverage at one time. And then we have the gastric bypass, which is a more classic procedure. 80% of the stomach is also sort of taken out of commission. It actually stays in the tube, but is no longer part of the digestive process. And then there is a second part where the duodenum is bypassed, and then so food from the gastric pouch then goes to the jejunum. So this is also restricting the amount of food that people can have at one time, as well as nutrient absorption and different hormonal changes that happen because of the bypass. This is about 15 to 20% of procedures that are done for weight loss. So most of our patients, if we refer to surgery, are going to get that vertical sleeve gastrectomy. So if your patient decides to, or if our patients decide to go for the surgical option for various reasons, medications are not an option, it's not something that they desire to do long-term, then we discuss surgery with them. That can happen with weight management providers such as me or Diana, or often with primary care providers. The first step is to get a consultation with the surgery team. It requires a prior authorization if you have Medi-Cal. And then we send them often to UCSF or another provider depending on the insurance. When they see the surgeon, there's a preoperative evaluation that's required, including blood work, cardiac and pulmonary clearance if necessary, nutrition counseling, and there is a psychological evaluation to make sure people are ready for this sort of permanent change. There is often a series of pre-surgery visits that are required by the insurance to demonstrate ability to make or commit to lifestyle factors. And then post-operatively, the patients need to take a bariatric grade multivitamin, calcium with D, and then for the first several months, ursodiol to prevent gallstones, if that's relevant. And they're often on a protein supplement, especially in the beginning when caloric intake is pretty small. In terms of post-op expectations for your patients, there's going to be frequent check-ins with the surgical team for the first few months up to a year, slow advancement of their diet from liquids to soft foods and then regular foods over weeks. Again, prioritizing protein intake as well as hydration, continued daily activity, including walking, and then again, that multivitamin, calcium, and ursodiol. And the multivitamin calcium are for long-term for life. Okay, so we'll just end here so we have enough time for discussion and questions. But in summary, Diana and I presented that people living with HIV have raising rates of obesity and related comorbidities. Sustained clinically meaningful weight loss is difficult due to both environmental and biological factors. Anti-obesity medications can result into that in that 5 to 20% weight loss in studies of 1 to 2 years duration. And then bariatric surgery, though didn't go into all of the data, is about 20 to 30%, sometimes more, in terms of long-term sustained weight loss. So yeah, we just want to open it up now to discussion and questions.
Thank you so much. That was wonderful. We'll start with questions from the audience and then we'll go to the chat. Let's do Matt.
Thank you so much. That was incredible. So I wanted to ask about an abstract that was presented last month at ID Week. So this was a randomized trial of semaglutide in people with HIV, who were all virally suppressed. They enrolled people with BMI above 25 and a high waist circumference and waist to hip ratio. And so they were interested in understanding sort of changes in body composition, DEXA scans, all of that, and saw weight gain or weight loss as you would expect. But they saw one concerning finding that in addition to decreases in total body fat, visceral fat, they also saw decreases in lean muscle mass, about 5% lean muscle mass decrease in a small study. The sample size was about 100. So I wonder if this is something that has been seen elsewhere, lean body mass loss in the setting of GLP-1 use, or if this is something specific to HIV. What else we know about that finding?
Yeah, so that's a great question, and it comes up a lot. Lean mass loss is associated with any form of body weight loss. So it has been well documented in the bariatric surgery population. In the sort of STEP trials, they haven't actually done DEXA data, and it comes up a lot. I was just at Obesity Week and everyone asks. We expect lean body mass loss no matter what we do. And so the important thing is this lifestyle intervention bit. You want to counsel patients on good dietary practices and also on doing strength training.
Actually, thank you. That was really great. And I learned so much. This is a follow-up to Matt's question, because in the discussion of that study at ID Week, we are more used to, there is also limb fat loss that occurs with HIV or can occur with lipodystrophy with HIV. And so there was a specific concern raised for the people living with HIV that this lean trunk mass, this lean mass body weight could also result in limb loss. And that was seen in a small subset of participants. So what do you, I mean, I know you can do exercises. I think that's what you're going to say, but I wonder if there's anything particularly concerning for people living with HIV in terms of cutting off the medication sooner, not having it a lifelong. That's my specific question. Would it be for shorter periods of time?
Yeah, so the lean mass loss that usually corresponds with the time that you've been losing weight. And so the real strategy or approach, depending on how much, how larger scale the study can be, is maybe patients don't need to go on as high of a dose, or maybe prolong the dose escalation so they're not having as rapid weight loss. So more lean mass loss is associated with more rapid weight loss. So maybe keep patients on each dose for longer. We never want to see huge amounts each month. So if someone in my clinic loses a lot in 1 month, we slow down the process or even dose reduce. And so maybe in your patient population, it's even more nuanced to stay at the lower doses for longer.
Thank you. That was really great. And it's such an exciting time. Two comments to make. One is that I think there are data emerging for people with HIV, which is really great. There's an ACTG study, 5371, that we'll get data for soon for fatty liver and some others out there. I think in general, while we don't have the final results for some of them, there haven't been safety signals. So from my perspective, the pancreatitis, that I don't worry about that in the modern era for HIV as much. Gallstones to me feels like more of an obesity issue rather than an HIV specific issue. So I don't know that we would need separate different monitoring, especially as we have more emerging data. But your point is well taken that things are changing. My question to you is one, why would you ever do then bariatric surgery if it looks like, I can't remember, the Zepbound is like as good, and then you cut somebody open. And the second is people with a BMI of under 37 can still have huge complications, and this is a group that's just like totally left
under
behind.
27?
Under 27, sorry, and that's just a really hard group. We don't have any. We've got these amazing options. And then if you're under 27, you've got really nothing that's anywhere near as effective.
So good question. So why would anyone choose bariatric surgery in this day and age? Well, number one, good luck getting a GLP-1 these days. But it's truly an individual decision, right? You present the two options, and that's what we do. And everyone has an opinion, and I will say half the people that, we see who want 20% kind of weight loss will opt for surgery, and they have their own reasons. But a lot of it is the daunting idea of taking a long-term medication for that sustained weight loss. Because we know if we the multivitamin, the calcium. Yeah. The ursodiol is only for a temporary period of time. And then you have the balance of maybe they're going to come off their diabetes medications and some other hypertensive medications, right? So on balance, you're swapping some pharmacologic agents for, a vitamin and calcium. So yeah, it's definitely an individual decision. And then the second question was, yeah. That's a really good question. I mean, recently, the bariatric surgery has become recommended for lower BMIs. It wouldn't be as low as a 25 BMI, but certainly there are international studies that show metabolic benefit in things like South Asia or East Asia, where, a BMI of 25 is overweight, it has excess adiposity. So I do think we will hopefully get to that where we can look at everyone individually as their excess adiposity for that person and what the ramifications are, and therefore be qualified for appropriate treatment. Yeah.
And there's a follow-up question in the chat related to that. Do you ever use, related to basically visceral fat, do you ever use DEXA or any other tools to quantify visceral fat or define the type of adiposity, say in a patient like Annie was mentioning that's not quite meeting BMI criteria?
Patients have to pay out of pocket. So at UCSF we do, but I kind of encourage patients even not to, because it doesn't matter, right? Like patients, insurance companies aren't going to cover it. The medications are really expensive out of pocket. And I don't feel comfortable, I really try and present that step 1 extension phase and step 5 study to show that this isn't something for 3-5 months. This is a lifelong $1,000 a month commitment. But in an ideal world, we would do that. And the other thing for surgery is versus medications. Medications don't work for everybody. The side effects are very common and are not tolerable for everybody.
That's great. One other question in the chat, we can go to the audience, is related to side effects. Any advice on management of diarrhea when chronic for patients on semaglutide? And then a couple of people have echoed that.
It's tough. You kind of have to understand someone's tolerability of the side effect. And if it's something where it's like, yeah, it's annoying, but I can live with it, then you kind of increase fiber, or maybe think about having meals differently, make sure people aren't having super high fat meals, which can promote diarrhea. But for some patients, it's like they can't go to work, they can't go to their kid's soccer game or whatever because the diarrhea is so bad. And then you have to have sort of a real conversation that we don't want this to inhibit your ability to enjoy life. And there are other options.
All right, we have 2 minutes left. I'm going to go to you because we haven't heard.
So I'll be quick. I was just wondering in SELECT if you see a relationship between the degree of weight loss and then the degree of reduction in MACE risk.
Yeah, so I didn't present this because there wasn't like an hour for me to talk about all the studies, but in SELECT, the body weight loss was only 9.6% by the end of the 4 years. So it wasn't those high 12, 15% body weight loss that was associated with that 20% MACE reduction. It was only around 10%. They didn't fully delineate or show the data of all the exact correlation, but we know that that 10% was really a magic number. And in the discussion, they say, like, is it from just the weight loss? Is it the decreased risk of other comorbidities associated with excess weight? So lower rates of diabetes, lower rates of cholesterol and other things that may contribute big picture.
Okay, I have two questions. Sorry for the double question. So first, I mean, when we're prescribing buprenorphine, for example, we give kickbacks, so medications to manage expected or anticipated potential symptoms. And I'm curious if you have any go-to meds that you prescribe for people when they're starting these meds as a kind of pill in pocket in case they do have nausea or diarrhea, et cetera. That's my first one. And then the second one, I mean, I think the data is pretty clear that if you stop these medications abruptly, people regain weight quickly. Is anyone studying alternative strategies, tapering, sort of individualized approaches to kind of finding the right dose to minimize side effects while maintaining weight loss?
Yeah, go ahead.
I don't do pill in pocket. I don't think the side effects, like you shouldn't have side effects that require that level of control to manage them. I think that there's this totally wrong perception on social media of what is okay, but we don't want our patients to be that uncomfortable. The second bit is I'm sure people are looking at that, but there's nothing currently being studied because of all of the supply chain issues. So Novo and Lilly can't do all of those normal secondary studies because there's just not enough drug. The study lead for all of these studies actually presented at Obesity Week, and she said that the hardest was seeing the patients enrolled in the trials have to come off. And there was rebound hunger because they weren't allowed to be down titrated. They were just stopped. And so they transitioned those patients to things like Qsymia. But the theory is that people will need to come off for reasons, supply chain issues, family reasons, whatever. And so titrating down to come off is safer. And then really, really engaging in that intensive lifestyle intervention while they're coming off is really key. I don't know.
Yeah. The nausea effect of a GLP-1 is supposed to get better because there's a tachyphylaxis to that side effect. And so I think it's reasonable if you wanted to do like an anti-nausea medication in the beginning, but I wouldn't do that long term. So that might be fine for like your initial stages. And then other things that I've tried in my practice, my patients are running out of GLP-1s too. And so, you could try to get a less popular GLP-1, like switch to Saxenda.
That strategy doesn't work anymore because Saxenda is also now.
Yeah, and it's hard to get. Yeah, it's hard. So it's almost like a whack-a-mole game trying to figure out what's available. But yeah, crossing over to another anti-obesity medication that you can get is one option. Yeah.
We're going to stop there. Thank you so much. If there are additional questions, please come to the front. Thank you so much.